followed by a slide seminar on
lung and mediastinal lesion based on this is a case-based approach, and we are going to discuss the cases which are shared with you. Can you see my screen?
Yes, sir.
Yes, sir.
Make it full screen,
Yes, sir.
Rajiv, full screen.
Yes. Okay. So I'll just start my presentation by giving you just a brief overview about the lung cancer. We all know that now the field has evolved and we have moved long ahead from the diagnostic category of small cell and non-small cell, and there is a need to give a precise diagnosis because these tissues, most of the cancers are subjected to further molecular testing. So the current WHO classification, small cell and non-small cell carcinoma, just giving that diagnosis is not feasible because we have to subject these tissues for the further molecular testing. And the current WHO classification was published in 2021, and this classification is if you see, there are mainly structural changes, but in addition there are some new diagnostic entities has been added. And in this new WHO classification across all the systems, they have very nicely put the diagnostic criteria like a definitive, essential, and desirable. So I request all the attendees of this seminar to just whenever you identify any entity, just go through these diagnostic criteria so that it fits with your precise diagnosis. And there is a long list of the tumors which can occur in this area, but predominantly they are non-small cell and adenocarcinoma and its variants. They are the commonest one, followed by the squamous carcinoma. But you can get some rare tumors also in this. But the majority of the tumors are the adenocarcinoma and its morphological variants, and squamous carcinoma. So we'll discuss some of them during the sessions. And what is the diagnostic approach, especially because in these cases we rarely get resections. So this is the table from the WHO which terminology which you should use when you are offering a diagnosis. So there are different diagnostic terminology for when you're dealing with the resections and as compared to on the biopsy. So recommendations are although for the eyes, you should try to restrict the terminology non-small cell carcinoma as minimal as possible. ISC should be used, but it should be judicious. And the term large cell carcinoma, which many people used to use, is not given in the biopsy. And this is the just snapshot of the diagnostic approach which you should follow. First, when any case come to you, just see what is the morphological growth pattern. Is it adeno or squamous? Or so based on your morphological pattern, order the immunohistochemistry and try to restrict the markers as minimal as possible so that it can go for further molecular testing. So IC is required, but it should be judicious. And these are the diagnostic entities in which you definitely need a immunohistochemistry for further classification. So these are the list of the diagnosis in which it is required. And I request all of you to go through this. This is a very concise review published in Journal of Thoracic Oncology on the best practice recommendation for the diagnostic ISCs in lung cancer. So this is a very nice table, nice review with a concise table which can help you to guide through the diagnostic workup when you're dealing with the lung cancer. So with this, we can now move on to the cases. So we have so can you see my next screen now?
Yes, sir, we can see.
Yeah, so so there were some couple of cases which we have put over here. So who will be taking the first case? So I just read out the brief history. This is a 66-year-old male with a lung mass measuring 5 by 4 centimeter with a patchy consolidation. Patient also has a minimal pleural effusion. So these are the digital slides which were shared with you, you guys. So who's going to take this?
Sir, I'm Aarti Sharma, JR2 from Bharati Medical College. I will be taking this case, sir. Good evening, sir.
Okay. So can you describe what we saw in this case? What
Yes,
you
sir.
saw in this case?
So there are multiple linear tissue bits with few fragments and fragmented cores also noted, sir, of variable sizes and shape. The glands are noted, sir. All tissue bits, they show almost a similar morphology. And sir, some glands are branched, appears to be branched, sir. And sir, on this higher magnification, sir, uh, uh, so the lining of the gland, the epithelial lining of the gland, sir, that shows columnar to cuboidal epithelium with eosinophilic cytoplasm and vacuolated some at some places, sir. The vacuolated, sir. And sir, there is
So
apical snouting, yes, sir. It's at some places, sir. And the nucleus is pleomorphic with vesicular nuclei with not nucleoli is not very conspicuous, sir, and can be noted at some places, some cells, sir. And so I can see some tumor giant cells, sir, and carbon-laden macrophages were also noted at few places, sir. And so the lymphatic spaces at some places, sir, and the vascular places, sir, they are not involved. The invasion is not involved, sir.
yeah, so on biopsy, especially if not, so if you see obvious LVA or PNI, you can comment on that, but it is not mandatory. So, what is your impression based on the morphological description and of this case?
Since the glands are arranged in a acinar-like pattern, so more it
Yeah,
looks
so
like
that's
acinar.
what I was trying to get the information that this tumor has a acinar like configuration, and there is one area which has I have marked. So any comment on this area?
The micropapillary.
Micropapillary arrangement of the glands, sir.
Yeah, so this tumor. So what do you think this is the diagnosis in this case, and what will you offer in your report?
So I will go with the micropapillary carcinoma, sir. Adenocarcinoma.
So that is that.
Adenocarcinoma with micropapillary pattern.
So is that so here if you see the dominant pattern is acinar pattern, and but at places there are micropapillary like area. So and in this another area which I focus now, it is also showing some cribriforming pattern. So this tumor has predominant acinar growth pattern, and but in addition it also has some micropapillary. So why I'm emphasizing on that you should comment on the patterns, although it is not mandatory, but there are some growth patterns like micropapillary, solid and cribriform. They are as likely to behave poor, have poor prognosis as compared to the acinar and lipidic growth pattern. So this was nicely described. I think any ISC do you want to do in this, and if yes, which marker?
Since I'm thinking, sir, since it seems to look like adeno, so sir, I would like to go for TTF1 and napsin, sir, in this case.
So is why do you need two markers? Is don't you think one marker is enough if you and both of yeah
TTF1, but napsin if in other case like sir, we want to rule out small cell carcinoma, then we can go for napsin, sir.
Okay, so the main idea in this case, especially at least in this biopsy, you're not seeing any small cell area. The other other possibilities can be, is it a metastasis of a thyroid carcinoma, which can also show TTF1 positivity. So what is your impression on this image which is projected on your screen?
So it shows TTF1 positive, sir.
Yeah, so there is a diffuse strong positivity, and there should not be any doubt that this is a adenocarcinoma, and we have also of primary lung origin. We have also given this history that this patient was treated with the pemetrexed, carboplatin, and along with gefitinib, but after 2 years of stable response, the lesion shows progression. So, and these are the biopsy from of the same patient, which is showing this lesion. So what is your can you describe this, or what is your feedback on comment on this lesion now?
Yes, sir. So, since this is post-treatment, sir, after 2 years, the patient has deteriorated, sir.
Yeah.
So these are also multiple tissue, linear tissue bits, sir. A few are fragmented, and with this, in this tissue bits, sir, I can see the sheets and nests of cells, sir. And sir, I can see a column of cell, and sir, on higher magnification, so the cells have scanty cytoplasm, and nucleus is NC ratio is high, sir. And mitotic figures are also noted, sir. And the individual cells, sir, they are loose, sir. And hyperchromatic nucleus, no evident nucleolizer.
So as compared to the first biopsy of the same patient, do you think it is the same tumor, or is it some different tumor?
Sir, that glandular pattern has disappeared in this, sir.
Okay.
The more of the sheets and nests I can see, sir.
Okay.
And sir, nuclear overlapping is also there. And sir, at some places I can see, sir, I think nuclear molding, sir. And sir, the stroma is desmoplastic.
Okay. So do you think this is the same tumor which you have seen earlier, or is it something else? And if yes, which markers would you like to do now in this case?
Sir, this morphology seems to be more of small cell carcinoma, like, sir.
Right. So you are absolutely right. It is morphology is more like a small cell carcinoma. So which markers would you like to do now?
Sir, I'll go with cytokeratin, sir.
Okay, cytokeratin. Why you need cytokeratin?
Sir, because small cell carcinoma cytokeratins, they are positive, sir. Like,
Okay.
sir, and of course, sir, napsin A will be negative if I want to. Like, if this is a sequelae case for case 1, sir, then I would like to do napsin A also, sir.
Okay, so napsin A was done, which is negative.
Yes, sir.
Okay.
So then this is small cell carcinoma.
So which marker, which marker I have projected on your screen now? Any guesses?
TTF.
So TTF1 you have seen earlier. I showed you TTF1. That is a nuclear marker. So and this is predominantly cytoplasmic with some, or maybe you can say membranous, but it is predominantly. So any guesses?
Neuroendocrine.
So what are the neuroendocrine markers?
Chromogranin, synaptophysin.
Yeah, so this is a synaptophysin, which is strongly and diffusely positive. Okay. Do you need, is it sufficient, or do you need any? So this is another marker, which is neuroendocrine marker, which is chromogranin. So this is negative. So what is your take on this?
So I can't.
This predominantly looks negative, but there are very focus. I don't know whether it is projecting on your screen or not, but there are some dot-like positivity is there, and it is also showing focal positivity. And another marker which we did is a MIP1, which is pretty high. So it is so based on the ISCs and these markers. So how will you conclude this case? Both biopsies are from the same patient.
Initially, the case was one. So the first slide that shows adenocarcinoma as a pattern, but it could be metastatic carcinoma. So in the second case,
So do you think that both the tumors are now separate, but the patient has shown the progression and even in the lung also, although there are multiple lesions now, and this was the history which was provided to you. So anything from here, especially, just a second. So the patient was put on gefitinib. So anything, can you make out why I have given this particular history to you?
EGFR inhibitor, gefitinib is EGFR inhibitor, so, and
Okay. So this is a case of EGFR mutated adenocarcinoma with exon 19 deletion, and on progression it has showed a small cell transformation. Okay, so the patient of lung adenocarcinoma who show the progression, so on biopsy there are two options to the clinician in such cases. Either they do the rebiopsy to find out what is the reason for the progression, or they can go ahead for the liquid biopsy. And why it is important? Because there are many second or third generation TKIs are available for the patient. And so morphologically, small cell transformation is one of the common reason for the transformation in a EGFR mutated adenocarcinoma. So we have, which for that you don't need any molecular test. It can be picked up on morphology. And in this case, there was diffuse involvement by the small cell, but it can be sometimes focal neuroendocrine. So that you have to convey in your report. And all cases who are on TKI for EGFR, you have to mention that whether you are seeing any small cell transformation or not in the biopsy. Okay, so these are the two alternatives which are present to the patient. But if on biopsy, if you see the small cell transformation, that means this patient has showed the progression due to small cell transformation, and that is the reason why the patient is not responding. Okay, George, any comments on this from your side?
Thoroughly enjoyed the discussion. Lovely case. I think only comment I can make is it'd be wonderful if the pathologist took cognizance of the radiology report as well. Then we could save on more IHCs, which I think is important. The TTF1 being positive with the right low lesion with mediastinal lymph nodes positive would give a clear diagnosis of adenocarcinoma without further need for IHC, and we could have saved the tissue for some other tests, is what I felt. And this transformation also in the small cell is a known feature after treatment with gefitinib. So the clinical history actually gives more clues to the diagnosis and probably will help a pathologist in reaching the diagnosis faster. That's only comment I could make. Lovely discussion. Thank you very much.
Yeah, and even if the patient who especially shows a small cell transformation, even if you invest on the molecular test, even those are also not going to help you much in such cases. So even you can avoid the further molecular test as well. So should we move to next case, or are there any questions for this particular case?
So we can go to the next case.
Okay, so the histories of the lung cancers, many patients, they present with a more or less similar case history, but this patient is a 56-year-old male with a history of smoking, and he was incidentally detected initially a very small lesion on scan for some other disease, but the lesion was less than 1 centimeter, so initially it was not addressed, but after 2 years, this you can see the lesion is quite increase in size. And George, would you like to throw some light on the third image?
So it's a ill-defined ground glass opacity, what we see in the 2017 scan. But you can see that it's serially increased in size and it's quite well defined with speculation. So highly suspicious radiologically for malignancy, and with the beginning of symptoms including hemoptysis, which means that it's connected to a bronchus or one of the airways at some point. and with a strong smoking history, high suspicion. I'm very surprised that nobody thought of biopsying it a little bit earlier, because a ground glass opacity which persists for more than 6 months needs to be biopsied.
Yeah, because but sometimes it do happen, and now I must say after COVID era, even in TMH also, we are seeing now a lot of early stage cancers, which we were not, and they are resected out and doing quite well also. So I agree. The patient should have been biopsy earlier, so that he could have been offered better chances for the management. And as George mentioned, that speculated margin on the imaging, it is very characteristic of a malignancy. So even for the pathologists, they should keep in mind, if you come across any report with the speculated margin, you should keep the suspicion of malignancy very high. So all these cases, most of them are the core biopsies, which are the common problem or you can say you will encounter most of the cases in thoracic as a core biopsy. So who is going to take this case? Or
So me, Dr. Rama, we are three medical graduates.
okay,
So,
good.
here we are able to see the 5 pores, which have two type of morphology. One type is gland formation with stromal reactions, and one is lepetic growth pattern. In gland formation, gland are lined by columnar cells, which show moderate atypia, and somewhere their capillary projections are there. And in lepetic growth pattern, alveoli wall are thickened, and we can see the stromal reaction as well, sir. And in the background, we are able to see the cholesterol clefts and a few inflammatory cells in the form of plasma cells and neutrophils. There are hemorrhage also present in the pore valves.
So these are the some area where which she was mentioning about the lipidic sort, because you can see these are the normal alveolar spaces, and there is a sudden transformation, and this lining is abruptly become dysplastic, and even on the top of there is one cell which is really quite large, just to label it as a reactive atypia. This. Okay, so do you think this is a malignant lesion?
Yes, sir. It is
Benign.
it's a malignant lesion, non-small cell carcinoma, probably likely adenocarcinoma, with an in situ component, lepetic growth pattern.
So when do you call adenocarcinoma in C2? And do you report it on biopsy?
No, sir, we don't.
And why? What are the diagnostic criteria for adenocarcinoma in situ? So, diagnostic criteria: if any lesion with purely lipidic growth pattern, which is measuring less than 3 centimeter in size, only then you should offer the diagnosis of adenocarcinoma in situ, and you should not see any evidence of invasion, no other growth pattern, no vascular or lymphatic emboli, no involvement of the pleura. So there are the few diagnostic criteria to label a case as adenocarcinoma in situ. So if in case you get a biopsy which shows only lipidic growth pattern, then you have to go back to the radiology and check for these features. Is the size less than 3 centimeter? Is it involving pleura or not, or any nodes which are showing high upticks? And if still you can put a comment in your report, the possibility of adenocarcinoma in situ is considered, provided these diagnostic criteria are met. Okay, so you should not offer adenocarcinoma in situ diagnosis on biopsy, because it need a complete evaluation of the resection specimen. Okay, fine. So in this case, your diagnosis is adenos or squamous?
Adeno, sir. Non-small cell carcinoma, likely adenocarcinoma, because it is SNR pattern of.
Okay, any ISC do you need?
Yes, sir. We can do TTF1 and nepsin A. Other
Okay.
usual marker like CEA and EMA.
Okay, so this is the ISC for napsin. Can you see the slide on your screen?
Yes, yes, sir. Yes, sir. It is positive, Nepsin positive, sir. It's Nepsin shows cytoplasmic positivity.
Just one second. Let me focus. Okay. So do you think where is the positivity for these the brown color which you are seeing? So this is the tumor which you are seeing, and the positivity for napsin is coming only towards the periphery. So where is the expression? Any comment on that? Do you think it is really positive in the tumor cell, or something else is expressing the napsin?
Actually, we do have various variant of adenocarcinoma. All the variant do not express Nepsin, like colloid and uh,
Okay, very good.
mucinous. Colloid and mucinous types are only fetal and fetal stroke.
What is your now impression on napsin? Will you call it positive or negative or focal positive?
Focal positive, I guess.
Yeah, there are some cells, predominantly it is negative. There are, if you really look into it very carefully, there are some cells, so like this whole gland look dysplastic, there is some weak positivity napsin, and you might, so in case you are lucky in this case, there were some cells which are showing positivity. So in case you didn't find any positivity, uh, do you ask for any additional markers? Or
Yes, so we can do CDX2.
okay. We have done CK7 in this case, although CK7 is usually, I don't do CK7 because it usually come positive in adenocarcinoma of lung, and as well as mesothelioma. Even squamous can also show you positivity, but if in a case which shows the negativity for lung specific markers, only then I order CK7. And is it positive or negative?
It is positive. It is strongly positive.
Yeah, it is strongly positive, and this area is showing the native lung alveolar lining epithelium, which is also showing positivity further. This is, as you said, you want to see the CDX2, but before going to CDX2, I'll show you CK20. And this is all, tumor is also positive for CK20. Okay. Now, and you want to see CDX2 as well. So there are, I'll just come to, yeah, there are some areas which are positive for CDX2, good number of cells. So based on this, now you have adenocarcinoma, which is strongly positive for CK7, also expressing CK20 as and CDX2, and very focal or weak expression for napsin. So how will you report this case based on this?
It can be a fetal or invasive mucinous type, I guess.
Yeah, so fetal adenocarcinoma has a specific morphology. It shows a subnuclear vacuolization, and usually it is it can be well differentiated, and many times it also is associated with some solid tumor nodule or morule like things, which can similar to that what we see in the endometrioid adenocarcinoma of the uterus. Okay, which is morphologically these features were not there, but so I will agree to your second diagnosis in this case, that this is adenocarcinoma with mucinous differentiation, and you have to keep in mind that invasive mucinous adenocarcinoma can be either negative or focally positive for lung specific markers, and this expression can be heterogeneous, as we saw in And in this case, and before you call any tumor, lung tumor negative for TTF1 or napsin, we have to uh, see them very critically on higher magnification, so that the clinical implication is that if you call it negative and ask for the evaluation of GI tract, then because this ISC profile is likely, if the TTF1 or napsin is negative, then the same profile will come with the tumors of GI tract. And there is a specific entity in the lung now is adenocarcinoma with enteric differentiation. So we have to be very careful and correlate the things with the radiology. So if you come across such case, you have to go back to your clinician again and ask for the imaging details. Is it really primary lung mass, or is there anything elsewhere? George, how frequently you come across such case scenarios where we come across with a little vague report and ask you to investigate other organs for the lung?
Yeah, as long as surgeons are very simple creatures, they don't look at only whether they can resect it or not. But this is something which we are seeing more frequently, especially in young Indian females. Finding a mucinous adenocarcinoma with a morphological picture radiologically like this is becoming increasingly common. So if you get a TTF1 positive, then we are virtually certain that it's adenocarcinoma of the lung. Otherwise, in the absence of any other radiological feature, we would be happy to treat it as a mucinous adenocarcinoma and continue treatment like in a lung.
Yeah. And one more thing I like to add, these mucinous tumors, they can be multifocal, and so even the critical radiology review is also crucial before a surgeon go ahead with only lobectomy, especially if you want to do a limited resection.
I'm happy Rajiv brought up that point. I just saw a patient today morning, adenocarcinoma, right upper lobe, non-smoker, with a small GGO patch in the right lower lobe. And again, we are confused as to whether it's a part of the same disease process, or since he had a fever 1 month back, whether it's a pneumonia. So it is extremely tricky to decide whether it's a primary or even a metastatic disease because of these ground glass opacities, which may be found in the CT scan.
And these lesions can be very tricky even for the pathologist to distinguish between reactive hyperplasia or atypical atypical adenomatous hyperplasia versus real mucinous adenocarcinoma with a lipidic growth pattern. So they can be really challenging for us also.
Yeah, and I think you should carefully look for your napsin or TTF1 because they may be very focal, and you have to give importance in such cases for your CK7 because there will be strong CK coming. Even if 20 is coming, then accordingly you'll have to try your cases.
Yeah, but Subhash, upper GI can show you same expression. Upper GI pancreaticobiliary tumor, they can show
Yes,
the
pancreatic biliary can show that.
Yeah. Subhash, you like to take next case?
Yes, sir.
Yeah, so I'll project from here.
Project from your side, sir. Yeah. So this was the history provided. The 60-year male with 5 by 4 by 3 centimeter mass. He was a chronic smoker. So who is present taking this case?
I can do it.
Yeah.
The section examined shows 5 linear true-cut cores showing lung parenchyma and predominantly maintained alveolar architecture with thickened alveolar walls, which are lined by atypical pneumocytes. There are focal.
Just one second.
Yes, 1 second. 1 second. Let us focus and then you describe. Right?
Yes, sir.
Okay.
So you describe as the focus is like whatever you see in that focus, you describe accordingly. Yeah, go ahead.
Can you see the screen?
Yes, sir.
Yeah. So, yeah, go ahead.
Wait a minute.
So,
Yes, sir.
Okay, please describe the lesion.
Sir, section shows alveolar architecture with thickened walls, and there is extensive fibrin uh, position. And sir, there is also on the right side. In the,
I,
oh,
So, can you see all this? What are these pink things? And did you see any normal structure in this section?
not in this focus, sir.
Yeah, not in this focus, but there was a bronchial lining. There was a normal
Yes, sir.
bronchial lining at one
Bronchial
end.
lining. So,
Yeah.
so which was so here.
Yeah. So can you do, how are the cells in the bronchial lining? What is the typical arrangement?
Sir, this bronchial lining shows high grade dysplasia.
High grade dysplasia. Okay, let us see. Why you want to call it high grade dysplasia? How what are
Because,
your
sir, on the right side there is stratification and the nuclear crowding.
okay, okay, and what else? So if you want to call this dysplasia, what other things you should look for in the epithelium?
The meson domain.
What? No, if you're seeing dysplasia in the lining epithelium, what else you should look for then?
Sir, lamina.
No. You want to see whether there is any proliferative activity, mitosis, if you can find out in the lining. See, because a normal lining epithelium will be pseudostratified. Can you see anything else in this lining epithelium on the upper side of this lining epithelium, the upper surface?
Sir, it seems like tumor diathesis, like the cells are breaking apart.
What is this pink thing on the top, at the top of the lining epithelium? If you see what Dr. Rajiv is trying to focus, this is a lining epithelium. At the top of the lining epithelium, yeah, what he's showing with his arrows.
Raj, can you be a little louder?
Okay, sir. So
Yeah,
can you see what is there in the arrows? Can you see what he's pointing out with his pointer?
No, sir.
Basically, these are your cilia, and normal bronchial epithelium will have your pseudostratified epithelium. So that epithelium may not always rest on the basement membrane; it may have a jigsaw thing. So what Dr. Rajiv is showing you, you can make out those feathery or under the setting. So there are those fine fibers. These are the cilia, which will tell you that this is a benign epithelium. And if you want to call it dysplastic, they will start losing their stratification. They will become more hypochromatic. We'll start seeing mitotic activity also in this. Okay, so this looks like a normal bronchial epithelium. Now we will focus on other areas.
Yeah, so you have to be careful. Sometimes you can get stratification in the bronchial lining epithelium. That doesn't make it, and it can look more blue. So that doesn't make it dysplastic. Okay, so you have to be careful. Carefully evaluate the normal structures or normal histological features of all of bronchi, bronchioles, tertiary bronchi, and alveoli. I've given you one more slide. Should I, anything else you want to see in this, or should I go to next slide?
Next slide, sir. Here, do you want to describe the alveoli and the parenchyma, how it is?
So the lung parenchyma is distorted and shows these pinkish deposition, which could be either fibrin or fibrosis, and can be also necrosis.
Okay, but you have to be categorical where it is located, the location of this, because necrosis may be more in the epithelial or the outside, and where exactly you see this pinkish material or eosinophilic thing.
In the stroma of the lung or the parenchyma, it's
Okay.
So, lung,
This
we have alveolar spaces which are completely occupied by this fibrinous material.
material, yes. So the
Okay.
stroma is the outside spindling cells, which is outside this pinkish thing,
So
which
there's
is
a one pink dark, pinkish material, and this is like some bluish or light areas. Those are the stroma. Normally, the lung there is no stroma, so this is the interstitium, which is
interstitial.
widened. Okay, so these are the two. If you can see my arrow, there are alveolar spaces, and in between there is some fibroblastic proliferation, which is causing the widening of interstitium. So normally in lung, you don't see any such widening of interstitium. Okay, so should we go anything?
Yeah. Anything else?
Please,
See,
can
so
you
there are
describe
some
it a little faster
so,
so that we can, because there are a good number
so
of
there are
cases
some
now.
interspersed cells like they were around the bronchial epithelium which were looking malignant like these.
Okay.
you describe how they are, like why you want to call it malignant, what features you see to call it malignant.
So they are high NC ratio with the one with the one or two prominent nuclei with the hyperchromatic nuclei.
Okay. Do you see any acinar or any other
No, no,
pattern,
no.
how it is arranged? Is that what solid islands?
Yes, sir. Nest and like islands.
Okay. And what about the underneath that island? There are two big things. What
Yes, sir. So
those?
they are giant cells.
So what type of giant cells you have to be classifying them? Whether there is a normal multinucleated foreign body type or any other type.
Some multinucleated giant cell can be tumor giant cell also.
Yeah, so these are tumor giant cells. You have to be specific about that. So okay, so on this HNE with this histology, what is your inverse diagnosis or differential you want to give on this case?
Here, may I just request you to summarize the H&E findings, and then maybe Sudhanshu can continue.
Okay, so basically we had this core biopsy in which there is, as you see, the alveoli are filled with this eosinophilic fibrin-like material, and there is this looks like an airless lung. The alveolar are lost. There are only few preserved alveoli. The interalveolar septa are widened and they contain fibroblasts. There are inflammatory cells in this, and in addition, there was a focus which was like a solid island with say a large the cells are large polygonal with abundant or moderate eosinophilic cytoplasm and large nuclei. So these areas definitely look malignant and they show a reaction also. There's an inflammatory response, fibroblasts, and along with this tumor giant cells. So Sudhanshu, with this histology which I described, what you want to offer as a diagnostic or differential, or you want to do any stains?
Yes, sir. I would like to do some staining. IHCs.
As in which IHCs we would like to
Like
perform?
like to rule out adenocarcinoma. I would like to do TTF1 or NEPSN-A.
TTF1. Okay. So this is your TTF1. Uh, any comments on the TTF1?
Looks like negative, and there are some focally positive cells.
So that focally positive cells, if we zoom in a little bit, then you'll have. Are these cells which are focally positive histologically matching with your tumor cells? Where are these cells which are
No, sir,
positive?
the tumor was very focal on the one side of the biopsy only.
Correct. So where are these positive cells? These are in the
These in the alveolar walls.
correct. So TTF1 is negative in the tumor and it's
Negative
positive in the alveoli cells. So now your TTF1 is negative. So does it rule out your adenocarcinoma?
Yes, sir.
Okay, but we saw a case recently which was TTF1 negative.
Negative.
So any other marker now you want to do it?
The CK7
Okay,
or
so
A11 or
Rajiv is
A3.
showing you one marker which is again a nuclear marker and which looks positive here. So what this marker could be with this histology?
So can we Nepsin?
Napsin is not a nuclear marker. It will be
Yeah,
as a
showed you
granular
the
cell.
earlier one case with an napsin, which is a cytoplasmic marker.
Yes, it has that cytoplasmic granule. So this is a nuclear marker. So what other tumor, if it's not adenocarcinoma in the lung, what other tumor should we think of?
So can be HCC.
HCC, squamous carcinoma.
Yes.
Which marker? So this which marker it can be?
Which marker this will be?
So P63 or CK56.
Okay, so this is a squamous marker. I think this is a P40, I think, which is also a squamous marker. So which is positive in these tumor islands. So basically, this was a squamous carcinoma, and in the background of what was there in the background? The lung. What did the lung showed?
So fibrosis deposition and inflammatory cells. Mixed
Correct. So
inflammation.
there was basically a consolidation. There was a pneumonia in the background. There was like hepatization. The alveoli were all blocked with this fibrin, and there is a squamous carcinoma along with that. So now,
are you comfortable to sign out this as a malignancy based on this small focus? Anyone can take this question. So,
Dr. Aarti, you can give an attempt.
Since the immunohistochemistry is pointing towards it, so you can consider that in DD.
No, we have to sign out this case and give the report to Dr. George so that you can treat the patient accordingly. So, are you comfortable, because these are the two very tiny focus of a tumor and background is showing lot predominantly. So, what is the impression on the final conclusion on this area and this area?
It could be organizing pneumonia. Sir, it could be one of the sir, no, I won't be considering it as carcinoma with two foci.
So, Dr. George will tell you there is a 5 centimeter mass, and you are telling me this is not a malignant, or you are not confident. But will you? George, can you tell what could be the possible reason that we are not getting a proper tumor in this case, and predominantly showing the pneumonia, classic pneumonia-like picture?
I think something there is a central component, and it causes a significant amount of consolidation in the surrounding area. So most of the tissue might be the needle traversing the consolidation patch, and the tumor might be at the end of the needle. So it basically, in cases like this, sometimes we prefer to do a PET scan to find out which is the most active part of the lesion and follow by.
yes, that is the reason that there will be a sampling error, because the lesion, so even this pneumonia was been expected to be a tumor, and most of the biopsy was showing this. It's like a sampling error.
Yeah, so the message is, even if you get a tiny focus, which is definitely you feel is atypical, you should raise the suspicion of malignancy, but with a word of caution, because there is a lot of predominantly the cores are showing changes of pneumonia. So this is and if you are not convinced about it, and if there is a clinically the surgeons are not happy with this, they will go ahead with a repeat biopsy from the PET avid area, as George mentioned.
Yes.
Rajiv and Subhash, I have to leave the meeting now, but I must thank you for inviting me here and lovely cases. Only, uh, you picked the right cases. I just wanted to put it to all the young pathologists that achieving a diagnosis in most, including the lab and the clinical scene, is about putting two and two together. So in the first case, it was a history of a lung mass and the TTF1, which could have clinched a diagnosis. In the second case, it is a strong smoking history with a speculated mass, in spite of the not conclusive IHC, which would have pushed the diagnosis towards the lung cancer. And the third one is the imaging and the consolidation, which you can see on the radiology. So putting all this information together helps the pathologist reach a diagnosis. And it's almost exactly how a surgeon functions when in the clinic as well. We gather all the information. So I would request you to, pathologists to talk to the surgeons and the radiologists before actually putting up a diagnosis, which is what physicians do in the clinic as well. So all the best. Thank you very much for inviting me. Thanks, Amit.
Thank you so much,
George. We'll miss your comment for the next couple of cases. And
Next
we'll
time.
try to be a little fast now.
Yes. Thank you. Bye.
Now we move on for the case 4A.
Sorry, sir, actually, we just had one question. The previous one, the pneumonia, can we call it acute fibrinous and organizing pneumonia in the background? I mean, on the morphology and the histology.
So on morphology, if you see, this is a gray hepatization phase of the pneumonia. Okay. So if you want to just give me a second, I'll show you a classical case of how the organizing pneumonia will look like. Just because organizing pneumonia will show you a lot of fibroblastic proliferations in the Masson's bodies, also in addition to the this case has it has mainly the fibrinous exudate, so it is like a phase of consolidation, not typically fitting into the diagnostic criteria of organizing pneumonia. So let me just, so this is what you see in the typical organizing pneumonia. There is a lot of proliferation, and these are the Masson's bodies, and which are you can see there is a loose fibroblastic proliferations, and this is one of the airways where the activity is happening around the airways, and this is again these are the Masson's typical Masson's body, which are the loose fibroblastic plugs which are filling and pushing towards the alveolar spaces. So this, when you get this type of picture, that is a classical what is described for to offer a diagnosis of organizing pneumonia. So this the current biopsy is still in the phase of the consolidation, and it will most likely it will resolve by its own because we are seeing only fibrinous exudates, hardly any inflammation as compared to this case where there are a lot of fibroblastic foci as well. Okay, so this is a book picture of a typical organizing pneumonia. This was a case of a carcinoid tumor which is obstructing the bronchi, and in the distal airways we are seeing this picture. Okay.
Okay. So another question I think Dr. Rama only has is by any chance can we think of amyloid, the pinkish material that we were seeing?
So that is a good differential.
Good question, actually. That's
and a good differential. So
Yeah.
how Subhash, can you tell the difference between fibrinous exudate and amyloid? So how?
Yeah, so if we see this fibrin, amyloid will be little pale, but they're more homogeneous that way. Whereas fibrin, there'll be little like granular texture will be little granular, and the location they're sitting in the in the alveoli in the clinical setting. But nevertheless, there'll be a lot of overlap like sometimes you might think that this is an amyloid or a fibrin, but if you see finally this fibrin has this granular or irregular texture, whereas amyloid will be little more homogeneous in that way. And but you'll have to, if there's a doubt, you always do your stains, do your Congo red, and do your negative birefringence. So that can be a differential in that way.
Okay.
So
Let's move to next case. So
so I'll take the case, sir. Yeah, I'll take this case. So this was the history provided, 57-year lady, and there was a long mass. With there was a 4.5 by 4 centimeter lung mass, and there was hemoptysis. So now we'll see the HNE slides. Who is presenting?
Sir, I'm Dr. Adisa. Good evening, sir. I present this case.
Yeah. This is
Sir,
again
I can
core
see-
biopsy. Yeah.
Sir, I can see multiple linear tissue cores, along with which few are fragmented, and if I look at the larger tissue bits, sir, the few areas of hemorrhage on the lower side, sir, could be seen.
Okay.
this
And
is
a seed-like
this
pattern, sir.
type of hemorrhage is procedural hemorrhage. Okay,
Yes.
you have to.
Okay, the procedure.
And these are the procedural. You have to be pulmonary hemorrhage versus procedural hemorrhage. You have to be very clear. That might be relevant, especially you see in the autopsy cases. And when if you offer hemorrhage, you have to be very certain about that in the lung, because that patient will be literally gasping if there is a pulmonary hemorrhage.
And this particular area, sir, I can see sieve-like pattern, sir. The sieve-like pattern, which seems to be more of cerebriform pattern, I can see, with eosinophilic material in between the spaces. And so on this higher magnification, the cells are seems to be arranged in a nest form, sir, nested form. And a few areas sheets could also be identified, sir. And the cells in the epithelial lining are polyhedral, and they are some are elongated also, sir. And mitotic figures are also noted, sir. And the nucleoli in them are not they are inconspicuous, sir, nucleoli. And the epithelial lining, sir, they show, yes, mitotic figures, sir. And sir, few areas carbon laden macrophages were also noted, and the lymphatic spaces, they are also so normal. They are not invade. I mean, there's no invasions in them.
Okay. And what about this area which Dr. Raju is focusing?
Sir, the stroma, I can see the stroma, sir. And sir, yes, sir, the space, it has, sir.
So
the
this is
stroma,
the core which is there, which Dr. Rajiv is focusing. Describe this area.
Is it
sir,
similar to
the stroma,
which you have earlier described, or is it the something else?
the sheets could be seen, sir. In this.
Okay. And do you want to describe a
And-
little more?
And sir, the stroma have
These
RPCs
islands,
and
these islands,
islands. Yes.
which has been focused. Do you want to describe this? What are these? This is stroma, or this is something else?
So these are the sheets of tumor cells, sir. And
Okay.
along with that, the stroma could be seen, sir, in which few inflammatory cells are also noted, sir.
Yeah, but these tumor cells are different from, I mean, the architecture, the pattern is different from what you described before.
Yes. Yes, sir. Because here I cannot see the cerebriform pattern, sir.
Correct.
So what will you
But
describe
what you
this,
see?
this pattern? How will you describe this pattern
In the this one, sir. Yes, sir. Sir,
So there are two patterns. One is in these two cores, which is looking slightly different from the one which is in the lower core.
sir, it seems to be more solid pattern, sir.
Yes, good.
Correct.
want to hear from you. Okay, a solid growth pattern. Okay.
So these are solid areas, and you have a tumor which is in the cribriform pattern. Even if you see this looks this looks little more eosinophilic, and these areas look more basal or basophilic or more monochromatic. Even the cell type looks little different. So with this histology, what do you want to think on this slide?
Uh, with this cerebriform pattern, sir, I can keep primary adenoid cystic carcinoma, which is quite rare, sir, but as a differential.
Okay, adenoid cystic usually has those punched out spaces. But then what about those solid areas? Because adenoid cystic will have more of a basaloid histology. Yes, the solid areas were not looking basaloid; they were more eosinophilic.
The thing, adenocarcinoma, solid pattern.
Okay. What
Okay.
else?
Or anything else? You have two different patterns.
Basaloid squamous cell carcinoma, another differential.
No. Your adenocarcinoma pattern, we are uh, we are sure that there is an adeno. There's a fused glandular or a cribriform architecture, which is quite diagnostic for an adenocarcinoma.
Yes, sir.
We are now contemplating about the second patterns, the second component. What you want to call those? Okay, so how would you like to go about now? What would you like to do next?
So, so I would like to go for a history of salivary gland examination by the clinician, sir. And if it is ruled out, then, sir, I'll go for IHC.
Okay. So what IHCs would you perform?
So I consider it as adenocarcinoma, then TTF1, and then to rule out primary adenoid cystic carcinoma, sir, then CK.
So there is one IHC focus. There is one IHC which is focused for you, which is a nuclear state. So
Yes, sir.
yeah. So positive, negative.
It's positive, sir, focally.
Are you seeing anything specific on the pattern of expression of this TTF1?
Yes, sir. It's more of a acinar pattern.
No, miss. What I want to ask you, there is an area which is very strong,
Very strong.
and majority of the areas are showing a weak expression. So it is like a heterogeneous expression.
Heterogeneous staining pattern you can make out in this. There are weak areas, there are moderate, and whereas strong areas.
And as compared to, you can see these are the normal pneumocytes which have a nice strong staining, and the tumor is weakly positive, but it is positive. Okay, so are you interested to look any specific areas in this case?
Those cribriform patterns I would. So
Yeah,
these are negatives, sir. What I wanted to ask, sir, actually.
So these are those areas which with cribriforming, and they are showing positivity. It is a weak positive.
So these areas are positive. We should look at whether there is expression in the solid areas also.
Yes, sir. Solid areas, sir.
What do you think? Is it positive?
This is also negative, sir.
Negative. Good. So
now what next?
I'll go for, sir, P63 kit.
okay. So now you can you see distinct areas of positivity and where it is coming? Is it positive or negative now?
It's positive now, sir.
So in which area?
So in the solid area pattern.
Yeah, so solid area, and we go back to the cribriform area. Is it Positive or negative here?
Negative, sir. It's negative, sir.
Okay, so
So now, what do you want to see? So you have a tumor which was TTF1 positive with TTF1, and there is a P63 or P40 positive in the solid areas. So what do you want to offer as a diagnosis?
Sir, P63 is positive, sir. Sir, your voice is. Sorry, sir. Please.
P63 is positive in that solid areas, the solid areas.
Sir, if P63 is positive, then it goes more towards the primary adenoid cystic carcinoma.
what about that TTF1, which is positive?
Yes.
Will you disregard that?
Could be a mixed pattern, sir.
So what would be that mixed pattern? What diagnosis will you offer based on this? Any thoughts from other residents? So you have seen the case.
Adenocarcinoma.
Sir,
Adenos-
adenoscoma, sir, both.
Could be squamo sir.
Adenoasclerosis carcinoma.
Adenosquamous carcinoma, sir.
Okay, so
No.
yeah.
Okay.
So-
Why you are calling it as adenosquamous?
Because TTF is positive, sir, and it is positive always in, 90% cases in adeno, sir. So, and P63 is positive in squamous, sir. So,
but
Yeah, I am projecting another case, which is a tumor here also arranged in a solid pattern, and I'll just quickly show you the ISCs of this case. Okay, so this is one stain is TTF1. This is positive, and this is P40, which is also positive.
adenosquamous, sir. Because
So-
P40 will be for squamous and TTF for adeno.
Okay, so do you think both these cases, this case and the one which we showed to you, both are adenosquamous?
No, sir.
But that previous case is different from this case, sir.
So what is the diagnosis in the previous case and what is the diagnosis in this particular case? And why? So what can you?
Yeah. So basically, is adenosquamous an IHC diagnosis, first of all? So what you have to see is, in this case with Dr. Rajiv showing, you have this tumor which is TTF1 positive, and these areas are also showing P63 positive. Whereas if you see the previous case, we had two distinct areas, not the overlapping areas. We had two distinct areas which were TTF1 positive and which was a P63 positive. So to call anything adenosquamous, basically in biopsies you don't call adenosquamous. You can raise the possibility because adenosquamous is a diagnosis of resection. So where at least 10% of the tumor volume should be of either component. So in the second case, the larger focus which was there, in which both are positive, is actually not adenosquamous. It is actually an adenocarcinoma because your TTF1 is positive, which we should, like this case. So this case, even if it's showing your P63 positive, your TTF1 positive, so TTF1 takes an upper hand and it becomes like a poorly differentiated adenocarcinoma. It is not adenosquamous. Whereas in the case which we are discussing in the meeting is two distinct areas. So that case you can raise in your biopsy, you can say that there's a tumor which is showing two components and raise a possibility of an adenosquamous because that requires a resection. So is it important to distinguish or label this like an adenosquamous or an adeno or a squamous? Is it important for the clinician and for the patient?
So, one important message which we want to convey with these cases is means for adenosquamous, you need to have a distinct areas, only then give a diagnosis of adenosquamous. Second thing, if adenocarcinoma with solid growth patterns, they can show focal expression of P40. That doesn't make change the diagnosis to the squamous carcinoma. And if the PTF1, the importance of PTF1 expression is more as compared to the P40 expression.
Yes, one will take your upper hand, and this will be an adenocarcinoma. So what is
And
important is that these tumors will have a poorer prognosis as compared to the individual adeno or squamous. These are poor prognosis.
And also these cases should also be subjected to the molecular testing, because earlier it was presumed that only adenocarcinoma should be tested. So even there can be chances that due to sampling you can get a only squamous component and not the adeno component in a particular biopsy. But in such cases, go back to the clinician, ask about the serum CA levels. If it is raised, then it is more likely to be adenocarcinoma.
And the problem comes when there is a metastasis. The metastatic focus may contain either usually it contains the dominant pattern, but you may get only one pattern in the metastasis, only squamous or only adeno. It's important to look for the tumor markers, the serum CA levels, and then you can get an idea about it. Okay, and these tumors you will have to do the molecular markers like EGFR. So that was the message. Now we move for the next case.
Subhash, take this case.
I'll take. Okay. So this was a 64-year male with a history, with a given history, and there was a 4-centimeter mass in the CT. You can see the mass in the CT, and there are this perihilar enlarged lymph nodes. Okay. So this was the history, and now we see the slides. So who is describing can go ahead. So these are the biopsy fragments. Any comment on the type? Because till now we saw only core biopsies. So any comment on this? Okay, go ahead with your histological description.
You are seeing a big chunks of the tissue now, which is, so it is a bronchial biopsy.
Yeah.
So usually in the CT guided biopsy, they are like a needle core biopsy. So this is a.
So till now we saw all those slender cores. Now this is a chunky or fragments. So this is like a transbronchial biopsies. So anybody who is describing?
Yeah, please describe this lesion, and we have to be a little quick so that we can quickly finish all the cases. Otherwise, we have to skip some of the cases.
Yes.
Depending on the how much time Dr. Gujral allot us.
Sir, in this chunk of biopsy, sir, I can see the solid sheets of cells and column, and the cells are also arranged in columns, sir. This is a solid sheet pattern, sir, and intervening necrosis is also evident, sir, and frequent mitotic figures are there, sir. And small to medium sized polyhedral cells, sir.
Okay.
And they're loosely arranged and vesicular nuclei with some having vesicular, some having inconspicuous nuclei, sir. Not all I can see nuclei. In all cells I cannot see nuclei, sir. And multinucleated giant cells, sir, I can see, sir, here. And so the background, it shows edema, sir. So not in this one, but on our lower
why I put this area, because you can see even the borders are also quite distinct in this some of the cells.
Yeah. So
yes, cell borders are distinct. So.
Okay. So, what is your impression? Malignant or benign? If malignant, what is likely diagnosis, and which ISCs would you like to do?
It's definitely invasive, sir, because the air spaces are also not quite evident, sir.
Okay.
And sir, there are few cells in which so mucus is also there in that because the
And any comment on the cytoplasm, especially in these areas?
they have foamy cytoplasm, sir.
Yeah, foamy vacuolated cytoplasm.
Yeah, they are abundant, they're foamy, some have vacuoles.
Yes, sir. Vacuolated
They
cytoplasm.
are arranged in flat or solid sheets. So with this histology, what we want to see comment upon?
Sir, could be squamous etiology.
Squamous, okay. So what you should look for if you're thinking of squamous, then what you should have searched in the slides.
Sir, please can you repeat the question, sir?
If you're thinking of squamous, then what you should look in the biopsy or in the tissue sections? What you should focus on?
Keratinization, sir.
So did you find any keratinization? Did you find any keratinization?
Yes. So it's more like so. No, sir, it's not quite evident, sir. Glandular formation, yes.
Correct. And even you describe you found somewhere foamy cells and vacuolization and something called mucin, you said. Like all this you usually don't get in squamous cells. Although the cells are polyhedral and all, but you don't get this type of cytoplasm. Squamous will have more dense eosinophilic cytoplasm.
So which ISCs would you like to do in this case? And we'll show you the ISCs.
Sir, again TTF, sir.
So this is TTF1. Yeah, so any tumor, mostly we should start with the TTF1, and this is TTF1 is negative.
Negative.
Okay, next marker. Next marker.
Napsin, sir.
Napsin also negative.
Or negative.
Sir, with sir, it could.
Anyone of you can come up and give the answer, please. We have to move fast.
So next we should do P63 or P40.
Yeah, P40 was also negative.
Negative.
Can it be metastatic?
Yeah, it was a good thought.
Okay.
And
so
which markers will you do for that?
Yeah. So with this pattern histology.
And this was a male patient or female patient? Male patient.
Male patient.
Male patient.
TTF1, P40, P63 negative. So
CDX2, sir.
CDX2 is negative.
Negative.
CK7 and 20.
CK7. Okay, yeah. This is CK7. What is the comment on CK7?
It is strongly positive.
Strongly and diffusely positive.
Strongly
okay.
diffuse positive.
Okay, then anything?
What else? Now you have a lung mass with this. So what other marker would you like to do with this histology?
HNF alpha 4 alpha, sir.
That is a cytokeratin. How it will help? It is a CK7 is strong positive. So you know this is a carcinoma. So that will not help you subcategorize. We have to give a. We know that this is a carcinoma, and it has a morphology of non-small cell type. We have to give some precise diagnosis.
So uroplectin.
Uroplectin for what?
Yes, and uroplectin for bladder, uroplectin, and the PSA for prostate.
Okay, we consider those to be negative. Although we did not perform, but this was a lung mass with this strong 7. So we can go show the next slide.
So This is the one marker which we did, and it is showing cytoplasmic positivity. And Subhash will tell you why we did this marker and
So
why it is
yeah,
relevant.
so basically this is a HEPAR1. So if you see the histology, it was more polyhedral. It reminded of a hepatocytic look. So the histology was like an hepatocytic solid sheet, polyhedral, abundant eosinophilic cytoplasm in the HNE, no gland formation, no pattern. Although you can get the solid pseudopapillary, all patterns in in this tumor, but the histology was more solid like a hepatocytic, and it was negative for TTF1, P63. So in such cases, we usually try to rule out an hepatoid adenocarcinoma. It's a distinct variant. It's a distinct variant which will have negative TTF1, but will have a hepatocytic differentiation or hepatocytic marker positivity. So you can try for HEPAR, Glypican, these markers. And the combination is the 7 positive, which is more or less it is 7 positive because it's an adenocarcinoma, it's not an HCC. HCC will be 7 negative, a hepatocellular carcinoma. So this is like an adenocarcinoma which will show 7 as well as your hepatocytic differentiation mark. So that is how. So this was the case of hepatoid adenocarcinoma. So there was certain criteria initially that the patient should have raised AFP levels. Although these tumors can produce AFP, but that has been toned down. That you don't need necessarily a raised serum AFP level. Even the normal serum AFP level is acceptable. Earlier it was that all patients will have a raised serum AFP level. So this is it's a variant or special different type of cancer. Arginus 1 sometimes can help because they usually come in HCCs as compared to the hepatoid adenocarcinomas. So like Rajiv is showing, that it's a unique entity.
So it is a unique entity, but till date it has not found a place in WHO. But we do encounter in some cases which show these ISC profile, morphological features with the ISC profile, that is CK7 positive, TTF1 negative. So before leaving it at as a broad or vague, giving a vague diagnosis, if you do a specific hepatocytic marker, you can give a more conclusive diagnosis. But the unique thing about this tumor is it is usually seen in the males exclusively. They are very rarely you will see in the females. Heavy smokers, and they are usually negative for all known potential driver mutation or markers. So
yes.
So and clinical course is very aggressive. That is the unique thing about this this tumor.
And one more point is like sometimes the TTF1 can come cytoplasmic in these cases.
Yeah. So if you do the TTF1 in normal liver tissue, it will show the cytoplasmic expression.
Yeah, so cytoplasmic, the normal liver also shows cytoplasmic. So similarly, tumors also show cytoplasmic. That can be taken as a hint, but it's not always there. But that is it. So this was like an hepatoid adeno, and it's important because these tumors, as Dr. Raju said, that they don't have any driver mutation. Rarely they have, but they have a good. They respond to immunotherapy also. So that is why it is important to diagnose and categorize these lesions.
So only one question, quick question we have here. Why is CK7 positivity seen in these hepatoid?
This is a variant of an adenocarcinoma. It's not an hepatocellular carcinoma. It's a lung adenocarcinoma which is showing a hepatocytic differentiation. So it will have a 7 positive. Don't confuse it with an hepatocellular carcinoma.
That is very important marker to distinguish it from the actual hepatocellular carcinoma.
Because that will be negative for
carcinomas are usually negative for CK7. So if you see such a strong expression for CK7 along with hepatocytic marker, then that means it is not a HCC. It is a adenocarcinoma with hepatoid differentiation.
Okay, sir.
Preeti, how much time we have, or how many cases we can take?
Sir, I believe we can complete. It's fine, sir. We are on time. We have 2 more cases, right? 5 and 6, like 5A, 5B, and case 6.
We have in fact 3 more cases. Either we have to go little quick?
Yeah, maybe we can go.
Or if you want to finish all the cases, or otherwise we can.
We can go ahead. We can continue right now. Maybe finish it quick. Maybe that is the only thing. So any of the I would like the students, if you are not really clear, you can say, I do not know or something, and then, maybe
So
some.
Yeah, and other can chip in.
Yeah.
Yes,
Yeah.
yes. So this is again a 70-year-old male with a lung mass and the supraclavicular nodes which were enlarged, and the section which we have given you was from one of the node. So you can see rarely you see such a large tissue in when you are dealing with the lung cases. So it has a lot of tissue which is due to the supraclavicular node. Okay, so who want to take this case?
Sir, I'll do it, Dr. Sudhanshu.
Okay, go ahead, please.
Sir, section shows multiple soft tissue bits. There is no normal lung parenchyma or the lymph node parenchyma. I can see two different hyper and hypocellular areas. This is the hypocellular area, which shows mucin, extensive mucin, and as well
This
as
is to
these
tell you, this is not mucin. This is a bluish thing in the back.
bluish
It's more like a myxoid stroma. Okay.
myxoid stroma. Okay, sir.
Yeah.
And they are the singly scattered polygonal cells which
Very
have
nice.
which have a high NC ratio, and the nucleus seems to be in some of the cells. The nucleus seems to be pushed to the periphery, and the nucleus is hyperchromatic, with some of them showing one or two prominent nuclei.
Yeah. So you mentioned that these are some of the cells are showing a nucleus which is pushed to the periphery, and even I have marked some of these cells as well, and there are these such cells over here also. It's very nicely described about these. So, and one another area which I have marked is showing some cohesive
As a cluster of
cohesive clusters of these cells. Okay, good description till now. Any other area would you like to see?
Sir, in the hypercellular area, there are similar cells present, but there is no this myxoid background.
Yeah. So and
As well as some tumor giant cell were there.
yeah. So another important thing when we should start your thought process from the conventional things. So is it showing any glandular differentiation,
No.
squamous differentiation?
No, sir.
Yeah, so that means it is not like a conventional adenocarcinoma or squamous carcinoma of the lung. So this is looking something different. Okay.
Yes, sir.
So then what about these areas you have described? There are some cells which have a rhabdoid-like morphology. So what, based on morphology, if you have to give a diagnosis or a differential diagnosis, what would you like to offer?
Sir, poorly. First, sir, again, sir, this is poorly differentiated carcinoma. Can be adeno or can be squamous. That I have to see, or I'd say.
Can you confidently say that this is a carcinoma only, or can it be sarcoma? Because usually in carcinomas you don't see such a myxoid stroma.
Yes, sir. It can be sarcoma also, sir.
Yeah, it can be a sarcoma or can be a sarcomatous carcinoma, but the cells are very pleomorphic. Okay.
Yes, sir.
Okay, so with this history in background, which markers now would you like to see? Okay, any inputs from other? How will you start this case if you come across such case? Which marker? You have a lot of choices. You can start with any marker.
There was this lung mass present, so it can be a metastasis from the lung. So we can put TTF, CK, as well as to rule out squamous, we can do P63.
Okay,
and
so TTF1 was negative, P40 was negative. What other marker you said? Which additional marker you said? So all the epithelial marker except for this is a cytokeratin, which is weakly positive. So except for this, rest all common marker which we discussed till now, they all were negative. So, are you able to appreciate these cells which are showing some positivity?
Yes, sir.
Yeah. So these are the
Vimentin.
Vimentin. Vimentin. Why you want Vimentin?
Sarcoma markers.
Sarcoma.
Sarcoma. So usually, so Vimentin is not very specific for sarcomas. A lot of people do Vimentin, but many times it doesn't help because Vimentin can come positive in many carcinomas as well. And lung cancer, I did my part of my thesis long back on the lung carcinomas, and in which around 60% of the lung carcinoma can show Vimentin. So it is of not of much use to distinguish because carcinomas can also express. So
SMA.
SMA was negative, but he has described some rhabdoid cells. So based on rhabdoid cell, don't you think before SMA some other marker would you like to do? Yeah, you have described there are some eccentrically
Desmin, sir.
Desmin, yeah, Desmin, because if you say that it can be pleomorphic RMS also, that was also negative.
Myogenic.
So you name all possible markers. They all are negative, and I'll now show you one specific marker which was unique to this particular case. And what is your interpretation on this? Is it positive or negative or
The nuclear positive.
nuclear positivity? So positivity you are seeing in which cells? Small cells or large cells?
The small cells.
Small cells. So that means is it positive in tumor cells or not?
No, sir.
So that means I'm showing you one marker. So these are the native cells or some vessels or small cells which are showing the expression. So this is a case, this marker is lost in the tumor cells. Okay. So this ISC is a BRG ISC, and now in WHO classification of the lung tumor, there is a unique entity. Okay, that is a BRG associated thoracic SMARCA4 deficient tumors, which are characterized by loss of BRG expression, and the morphological features which you have very nicely picked up and described were typically seen in. So these cases are usually very poorly differentiated pleomorphic cells, can show you rhabdoid like morphology, and as we saw in our case, there is a loss of BRG or SMARCA4 expression in this case, and these are some of the other morphological subtypes which we can show the tumor with the BRG expression, and this tumor was newly included in the latest WHO classification, and we are also now able to identify some of the cases which can show the BRG expression. So these are the diagnostic criteria to establish a diagnosis of a thoracic undifferentiated SMARCA4 tumor. Tumor usually occur in the adults, which are diffuse sheets or discohesive round epithelioid cells, which are relatively monotonous and can show the rhabdoid like morphology. And there is a loss of SMARCA4 ISC. That is the essential criteria to make a diagnosis. But in addition to the SMARCA4, these cases can also show SMARCA4 loss because that is also a family of tumor, but and can also show the expression for SAL4. So this is the unique tumor which is included in the latest WHO classification of the lung cancer. So you have to keep in mind if you come across a tumor which showing such a morphology, so it could be a BRG associated BRG deficient tumor. So any comments or any doubts or any questions about this?
Just a basic question: how to differentiate myxoid and mucinous stroma?
Okay, yeah. So many time you do get and mucin in the background, especially in the adenocarcinomas. And so usually when there is a myxoid stroma, it at some places you will see some of the fibroblastic foci. And if still you are not very sure, then you can do the special stains like mucicarmine or Alcian blue. They will help to distinguish, but usually only mucin is more homogeneous and slightly pinkish blue, and rather than myxoid stroma, which is more towards the blue tinge of that. So although
Yeah,
sometimes you can
look for cells. Look for cells in the
yes.
stroma. Myxoid stroma will have some cells.
Yes, so that is the main thing which can help you to distinguish it.
And one more important is this is a negative marker, so that you have to keep in mind that BRG is a loss, and all the cells, the blood vessels, the inflammatory can become the internal control for it. So like you have INI1 loss, this is another kid which is a BRG1 loss, negative.
Okay, let's move to next case. It is a 22-year female. It is a young female with a lung mass with a mediastinal extension. And please come up and decide who is going to describe this this case.
Sir, I'll do it.
Yes, please go ahead.
So section shows multiple linear true cut cores.
Okay.
Sir, section shows sir, all the cores show sheets and islands of large polygonal cells,
Right.
which are monomorphic with hyperchromatic nucleus with moderate eosinophilic cytoplasm, and there is multiple areas of keratinization or the keratin pulse seen.
Right.
Oh,
Okay. You want to describe the cells?
sir, these cells are polygonal with high NC ratio with hyperchromatic nuclei.
Okay, so you are seeing nice keratin pearls, and which is surrounded by these cells, which are as you have described. So they are these cells pleomorphic or they are relatively monotonous?
Sir, monomorphic.
Okay. So if you see such case, what will you think?
Sir, squamous cell carcinoma.
Squamous cell carcinoma. Excellent thought, but maybe not the right thing. First thing, squamous carcinoma, small cell carcinoma in young female patients. You have to think 100 times before offering a diagnosis of squamous carcinoma. The patient is 22-year-old female. Okay. So non-smoker, young females, you have to be very, very careful if you label it as a squamous carcinoma. I agree. Morphologically, it is showing a nice keratin, and there are areas of keratinization, abrupt. We can say it's abrupt keratinization. So, any other thoughts about this?
No, sir.
No. Anyone else?
Nut carcinoma.
Nut carcinoma. Why nut carcinoma?
Keratinization.
Okay. And keratinization, as he said, it can come in the squamous carcinoma, and this is the P40 stain. Okay. This is P40 stain, which is showing you strong and diffuse positivity. So why you thought about nut carcinoma?
Like keratinization, abrupt keratinization.
Okay, and what else?
Aggressive of tumor like in sheets and
No, what you saw
monomorphic.
keratinization, the background cells, yeah, the other cells.
A monomorphic appearances.
Yeah, so in fact, this is a case of a nut carcinoma. Okay, so which is as you can see, this case has shown a relatively monotonous population of cells with abrupt characterization, as was very nicely described by you. But the diagnosis is based on the abrupt presence of abrupt keratinization, which is surrounded by relatively monotonous population of cells. And this is the specific ISC, which is a NUT ISC, which I am projecting on your screen now. And it shows, I don't know whether it is, you can appreciate that or not, but it shows a nice speckled granular positivity in the nucleus. So that is a typical pattern which is described for the nut carcinoma of the lung, and this is the tumor which you can encounter in the young patients. And so a tumor which is showing a relatively monotonous population of cells, which can morphologically resemble the small round new cell tumor, then you have to think about the nut carcinoma, because this is also one of the very aggressive tumor, and it is characterized by this nut BRD4 fusion. And especially about the lung nut carcinoma, you have to think that many times P40 can be negative. Okay, so and it can show very weak or focal expression. Otherwise, usually nut carcinoma, they are usually very strongly and diffusely positive for P40. And so you have to keep in mind, especially in the when you are dealing with a lung nut carcinoma, they can show negativity or very focal positivity for P40. Okay, so so this is also a specific diagnostic entity in the thorax, and you can see these tumors in the thorax, in the hilum, or in the nasal cavity, sinonasal cavity. Okay, let's move to next case. It is a 45-year-old female with the endobronchial lesion. Suvash, you want to take? You can discuss this case.
Yeah. So
as I mentioned, we have to now little quick. So wherever you get obstructed, we will take over from there.
I'll take the.
So this is this.
yeah, go ahead.
So in this, you can see multiple tissue bits in which, like one tissue bit show two kind of tumors. Like partly we can see sheets and nests of tumor cells, squamous looking cells in sheets and nests, which shows high NC ratio, pleomorphic nucleus with intracellular keratinization. Then
Okay.
and partly we can see part
So
of
this areas which you described as famous, is the NC ratio really very high?
nucleus are little larger,
Okay.
and intracellular keratinization can be seen,
Okay.
and cellular bridges can be seen. Nucleus are large with prominent nucleoli.
Okay, now describe. You said two different types of population.
And the second area, adjacent area, we can see tumor cells in nests and nest pattern, and the nuclei are the cells are showing high NC ratio with the hyperchromatic nuclei, and
is it really hyperchromatic?
it's goes blue. Few hyperchromatic nuclei are there, few nuclei are little pale.
Okay, what else?
Solid sheets are seen, and so is that acantho like I'm doubtful for that.
So in that monotonous areas or the solid areas, was there pleomorphism? Was it monomorphic? Did you see any mitosis?
It is
nested areas which you described.
mild degree of pleomorphism is the like similar kind of cells mostly.
Any mitosis you could identify?
Mitosis. Sir. Okay. Mitotic figures are also seen.
Have you counted them?
Counted them, because in lung
No, sir, I'm not counted.
Okay. So what do you think based on the morphology? What's your possible diagnosis?
A squamous component, squamous cell carcinoma component is there.
Okay.
And the second part of the tumor, it is like squamous itself with acantholytic or like some lumina are also seen, so I'm not sure that part squamous.
Okay, so which stain I'm showing you?
These are nuclear stain.
No. So you have described this.
You
You are
have
seeing
described
squamous-like areas, no?
squamous areas.
Squamous area.
So is it diffusely strongly positive, or what is
No,
the
no,
pattern of expression? How it is? Look at the pattern.
Bases.
You can compare from the right hand side. Look at this cell.
Yeah, as you rightly said, it has a basal-like expression, and
Yes.
you can see on the surface also there is only basal
appearance. So this is all basal cells which are positive.
Okay.
Okay, and the other area which you thought about, the acantholytic variant of squamous, is it positive or negative?
That area is negative.
Okay.
So now what else? Now what next you want to think? Because if it was a squamous cell carcinoma, your P40 or P63 should have come diffusely positive, which it is not.
CK5, CK7.
CK5, 6 had similar pattern.
This is TTF1, which is negative.
Okay.
Negative in both the units. You'll see the next.
What
Sir,
next you would like to?
So the first stain you showed was P.
It was P40.
P40. It was
Okay.
first squamous. So P40 was negative.
Negative.
This is TTF1, which is also negative in both the different looking components. So now what you can think of? What else you should think of? Anybody from
Emma.
chat? What did you say?
Let's go for Emma.
EMA is positive in all the cells.
Yeah.
It will not help you. Okay.
It will not help you to diagnose your entity. So now one stain has been focused for you. What it could be? Look at the stain and where it has come.
Mucin stain.
No, these are all
This is an immunohistochemical stain. You can compare and contrast. One area is negative, one is positive.
So as you described, these cells are quite monotonous. So when you see a monotonous tumor cells in a lung, you have to think about another set of tumor, that is a neuroendocrine tumor.
Synaptophysin.
Yeah. So this is a
synaptophysin, positive in the monotonous cell or the neuroendocrine-like cells, and the squamous areas are diffusely negative.
Okay.
So now what next? You have a synaptopositive.
This is another area stain to show this chromogranin also, which is also positive. Okay.
Chromo is also positive. You have this nice positive in the perinuclear zone.
And another stain which I am showing you is a MIB1 K67, which is pretty low. Okay. So
Carcinoid.
okay.
So how you want to go about how do you diagnose a carcinoma?
So do you think these squamoid areas are part of the tumor?
It is adjacent.
You could see the IHC pattern of P63. Do you want to draw any hint from that? Like, is it adjacent? But
Okay, so this, as I showed in the initial picture also, clinical picture, that this is endobronchial growth. So it was ulcerating the overlying mucosa and causing the squamous metaplasia, which is very common in the endobronchial tumors, especially in the carcinoid tumors and salivary gland tumor of the lung. They can show the associated squamous metaplasia of the lining epithelium, and you can mistake this for either for the squamous carcinoma and tend to ignore the underlying actual tumor area. So, and especially in this case, this carcinoma tumor, they have very good prognosis only if it is resected out and patient get a complete cure. But if you tell that this is a squamous carcinoma, then he might be subjected to a very toxic chemotherapy. So identifying the squamous metaplasia from the actual monotonous looking carcinoma tumor, you have to pay attention. And if you see that there is a lining also over here, which is in continuity with the metaplasia, so this is an ulcerated lining which has undergone squamous metaplasia. And if you see very carefully these cells, there is hardly any atypia, or mitosis, pleomorphism is not there. Okay,
so that's what we were trying to make focus, that there is no, as such, there is no atypia. This much atypia in a normal squamous is acceptable, as it is the cells are large, but the NC ratio is not high. There is no pleomorphism. We don't see any mitotic figures. So this was not atypical.
so let's move to next case. It is a 46 male and measuring the lung, small lung mass.
So who is taking, anybody?
So, this section show multiple tumor tissue cores with tumor cells arranged in nests and large nests, and individual tumor cells show nuclei of varying pleomorphic nucleus, and which is located eccentrically, and the cytoplasm is more eosinophilic and abundant.
Very characteristic amphophilic cytoplasm. It is used usually. Okay. Anything else?
I marked this area. This
atypical mitosis.
Yes, yeah, there is mitosis. Okay.
There's one more here also. So you have this tumor which has a kind of a nested arrangement or an object, and with these cells with abundant cytoplasm, atypia. So how you want to work up this case? Yeah. See, again, there's no mitosis here.
So this morphology is also quite suggestive of a tumor of which lineage? Huh?
Endocrine.
Neuroendocrine.
And how do you find anything different in this case as compared to the previous case? And we have specially showed you, I marked two areas where you are able to, we are seeing the mitosis as well.
Increased number of mitotic figures are seen.
Okay.
In previous case, they were small round blue cells. Here, the cytoplasm is more amphiphilic and abundant, moderate to abundant.
Okay.
It's a
Plasmacytoid cells.
mitosis is there. It may be atypical carcinoid, and oncocytic variant can be.
Yeah.
Because
So,
cytocartilage
so what are the diagnostic criteria for typical carcinoid, atypical carcinoid versus large cell neuroendocrine carcinoid?
Carcinoid, it is less than 2 mitotic figures per 10 hyperfield. And
One thing which all of you should remember now, for the neuroendocrine tumors, you should not tell the mitotic figure per 10 hyperfield. It is a 2 mm square area which you have to measure according to the field diameter of your microscope. Okay, so never use the word now neuroendocrine tumors as a for neuroendocrine tumors as a cutoff criteria for mitosis is based on the 2 mm square area. Okay.
then in atypical, it will be more than 2 to 10 or more mitotic figures will be seen per 2 mm square.
Okay.
And
2 to what is the range?
2 to 10 to more than 2.
More than 10 or 2 to 10?
Increased number, it is more than 10.
No, what
And
can you tell me the range what you mentioned?
less than 2 is for the typical carcinoid, and more than 10 for atypical.
No, anyone want to correct her?
Yeah, and there's the what about 2 to 10 then?
So less than 2 is typical carcinoid, 2 to 10 is atypical carcinoid, and more than 10 is a large cell neuroendocrine tumor.
Yeah, so those are the diagnostic criteria, and presence of, if you see the necrosis also, so then it becomes at least atypical carcinoma.
Atypical carcinoma.
Okay, so
For typical, it should be less than equal to 2 without necrosis. That is also.
we have done the MIB1 also in this case, which although it is not a very into the diagnostic criteria in the lung neuroendocrine, but you can clearly appreciate that this MIB is quite increased in this case. So it is not less than 2, which is for the other side neuroendocrine tumor. So it is definitely more than 2. But MIB1 is not as a not till date. It's not an essential diagnostic criteria for categorization of neuroendocrine tumor of lung. So this is a case of a neuroendocrine tumor, which is a atypical carcinoid. Okay.
And your large cell neuroendocrine carcinoma will show you more ATP. It's had abrupt ATP or on a sudden anisotropic.
I think now we are running quite late. Next 2 cases I'll just quickly describe for the benefit of attendees. Other than describing, so this is a 26-year-old female with a mediastinal mass, and the tissue core biopsies were there, and you can see. So if there are any inputs you want to give from your end or any doubt, you can clarify. But I think I will describe and just finish the discussion fast. So just a second. So what you are seeing, these tissue cores, they are quite rich, and the lymphoids, you're seeing a lot of lymphoid cells over here, and so you can appreciate that there are very monotonous small population of lymphoid cells, and at the same time, if you see very carefully, there are some cells which are slightly larger also, which are interspersed in between. But you're finding it very difficult to identify it on purely on the HE section. But if you see carefully, there are some pale looking cells as well. Okay. And which you can appreciate in these areas, and background there are a lot of lymphoid cells. And so when you encounter such lesion in the mediastinum, there are 2 differentials you have to keep in mind. Either it is a acute lymphoblastic lymphoma or is it a thymoma, because both of them can be rich in the lymphoid cells. Okay, and the ISC wise, if you think it can also be challenging if you go directly. So so in the thymic tumors, if you see both lymphoblastic lymphoma as well as the normal thymic tissue, they can show the expression for TDT. Okay, so this is the TDT which is showing a nuclear staining, and you're seeing a lot of cells which are positive for TDT. So is it a lymphoblastic lymphoma? Yes or no, based on the description which I gave you. Or do you need any additional ISC to support or confirm the diagnosis?
Sir, additional ISC we should do.
Yeah, which ISC?
CDA1.
Pardon?
Which one?
CDA1, sir.
CDA
CD1A, sir.
1A. CD1A also shows some focal positivity. It is positive in some of the cells.
What other marker will you do?
CD99.
That is also strongly and diffusely positive.
CD45, sir.
CD45 is they all are lymphoid cells. It is also positive. The most crucial marker here will be cytokeratin. Okay, so if you don't do cytokeratin, you will end up calling this case as a blastic lymphoma. And if you see, this is the cytokeratin, which is very nicely highlighting this like a fishnet network of the thymic epithelial cells. So this is in fact a thymoma type B1 and not a lymphoma. And this cytokeratin is the one of the most crucial marker which you should never forget, okay, to perform in any of the mediastinal lesions. So you should start in fact with the cytokeratin before you do any other marker. Okay, so if cytokeratin, if it is a negative, then only the role of other markers come into play. Otherwise, this is likely to be of thymic epithelial neoplasm, and this is an example of type B1 thymoma and not any lymphoblastic lymphoma. Suvash, anything from your end?
No. So that's what we'll start with the cytokeratin and work up accordingly.
And this is P63 or even the PAX8 will also show you similar expression. So these are all thymic epithelial cells. They are highlighted by P63. Okay, so this is another marker which can help you to establish a diagnosis. So cytokeratin and P63, these are the common one, and as compared to that, the background lymphoid cells, they are negative. Okay, let's move to next case of a thymic tumor, which is also from the mediastinum, and here the morphology is slightly different. It has more epithelial-like or ovoid to spindle cells, but we are seeing very less number of lymphoid cells in the background. Okay, there are some lymphoid cells, but predominantly you are seeing ovoid to spindle cells. So, any thoughts based on this morphology?
Sir, it is thymoma. It can be thymoma type A, which shows spindle morphology.
Okay, any differential? Any differentials? Other differential, close differential can be a neuroendocrine tumor, because spindle cell neuroendocrine tumors can show you spindle cell morphology. So that is another close differential which also you have to keep in mind. But this case was nicely and strongly positive for A1, A3, and usually neuroendocrine tumors, they show weak expression as compared to the thymic epithelial tumor. They show a nice strong expression, although there are some areas which has a broken network. And in addition, we should do TDT also in these cases, because there will be some cells which on morphology you're not finding so many cortical or thymic lymphocytes in the background, but this is a TDT stain which has picked up much more of these cells. So usually in type A thymoma, you see less than 10% of TDT positive cells. So which are, if you see in this case, they are slightly on the higher side, and there are some areas which are negative and showing very low expression. This can be possibly a case of a type AB thymoma, but on biopsy sometimes it can be difficult. So to distinguish between type A and type B thymoma, we have to rely on TDT. Okay, so if you're seeing more number of the cells, and even the morphology is like that of a spindle cell thymoma, then it is more likely to be type AB thymoma. So this is the diagnostic approach which you should keep in mind. You should see is it an epithelial predominant thymic tumor. If it is epithelial predominant, then the differential will be type A or type B3 thymoma. But if it is a lymphoid predominant tumor, then it can be either B1 or B3 thymoma. Okay, so this is how you have to keep approach a thymic epithelial neoplasm when you are dealing with it.
And in your type A and B3, like especially B3, you may not see your TDT positivity because those are predominantly epithelial, so you may not get your TDT staining.
Okay, so this is what I told you. If there are more of so the first case example is you're seeing a lot of TDT positive cells. It is type B thymoma. Last one is type A thymoma, and the middle one it can be a mixed type. So if you are seeing more than 10% of the TDT positive cells, then don't call it as a type A thymoma. And just to conclude the last case, this is again a young male with a mediastinal mass. And any questions or queries on the previous case?
No, sir, not on this one. We have one question we'll take at the end.
Okay. So this is another nice, just one second. Another case of a mediastinal tumor, which is showing these nest of tumor cells which have some cytoplasm, and you can appreciate some ill-formed granulomas also. Okay, if you are seeing the digital slide, there are some vague granulomas also, which are along with the nest of these tumor cells. And here there is another. There are some ill-formed granulomas also there. So any thoughts from the residents? What was this case? And here we are seeing more like a diffuse sheets of these cells with some vacuolated cytoplasm, and there are some lymphocytes which are sprinkled over here. Any thoughts from the resident sides?
Our attendees are saying differential as Hodgkin's, primary mediastinal B-cell NHL, or germ cell tumor.
Okay, now this can't be Hodgkin, because Hodgkin you see a large scattered atypical RS-like cells. It can be a non-Hodgkin lymphoma if you right. Okay, so that can be a possibility, but definitely not a Hodgkin lymphoma. So any other possibility?
If you see this cell morphology, in the cell morphology, and there are some scattered lymphocytes also.
It's Sazhin, so it could be squamous cell carcinoma, thymus or esophagus. Metastasis could be there.
So this is a young, relatively young male patient with these monotonous sheets of these cells with speculate cytoma. You have to keep a possibility of a germ cell tumor as well in such cases, and
You have a lot
this
of sprinkling of lymphocytes if you see around this with this monotonous population and only a mediastinal mass.
this is the ISC, which is SAL4, which is enough to clinch a diagnosis of a germ cell tumor. So this is in fact a seminoma of the mediastinum, which is positive for SAL4 and OCT34. Okay.
Granulomas, you get commonly scheminomas in the mediastinum.
So that is another
Clue
hint
you have
also. So you can get granulomas with the Hodgkin, but seminoma is another tumor which can show you coexisting granulomas. So this is in fact the case of a germ cell tumor. So that if possibility you have to keep in mind in addition to the lymphomas and thymomas or thymic carcinoma, because if you don't keep this possibility in mind, you are likely to miss it. So with this, we will come to the end of case discussion, and if there are any questions, we can take them.
Yes, sir. So one of the cases we had squamous metaplasia. So there's a question: how do we differentiate squamous metaplasia from well-differentiated squamous cell carcinoma? Because does the well-differentiated squamous cell carcinoma show much atypia?
Yeah. One of the important thing is like you identify the overlying epithelium, whether it is connected, because a carcinoma will be an infiltrative pattern. So if it is still connected to the overlying epithelium and it is not showing atypia. So well differentiated may not show much of atypia, but it will be an infiltrating pattern. So that polarity, the basal cell location and upward maturation of the cells. So that is which shows a normal maturation pattern that you have to look.
Okay. So another you've described it many a times, but just for benefit of students, how to describe monotonous population of cells?
Monotonous, like something which is very monomorphic. There are the cells. The cell next to the cells look similar. They don't deviate from each other much. Especially we use this terminology in neuroendocrine. Like the cells, all cells looks alike, they look similar, and there is not much of pleomorphism, that is variation in the cell size or the variation in the nuclei. So either cellular or nuclear pleomorphism is not there. So one uniform looking pattern of the cells. So Rajiv can add it.
Yeah, so that's what is very peculiar characteristic about the neuroendocrine tumors. Also, all the cells will look similar to each other. There can be anisonucleosis, but the appearance throughout is similar, and you will see the atypia or dysplasia in a lot of anisonucleosis or dysplasia, which are characteristic of a carcinoma. So neuroendocrine tumor is a very typical example of this tumor.
Okay. I think with that, sir, we have finished our Q&A session also. We have covered all the questions during our cases itself. So with that, I would really like to thank you both for these excellent cases and very interesting. Our audience were also totally involved and continuously answering as you were asking the questions. And I would also like to thank our students for the active participation. So thank you so much, everyone, for joining us.